And once factor E is ready to be split, it does the action, and then factor B splits into factor BB and BA. Now CP with BB acts like a CP convertase, leading to the formation of CPB. Small quantities that are continuously produced, and then the terminal pathway as usual. So this complement pathway has to have breaks, otherwise if it is continuously activated, it will lead to overdestruction of many things, including RBCs. So there are breaks, inhibitory factors, different ones as you can see here. I'll just point to two of them, which is BAF and BAL, CD55 and CD59, that we will talk about later. Now, PNH, how does it form? The inciting problem is a mutation, a somatic mutation within the X chromosome in a gene called big A gene. As you can see here, the big A gene is translated into a protein, which is important in the synthesis of the anchor protein, the GPI anchor protein. Now, as you can see here, it's very hard to point anyhow. Trying to focus on the picture. The circle is the anchor protein, and these triangles are the proteins that are anchored on the anchor protein. And these proteins are mostly inhibitory proteins that are important to inhibit the complement cascade. Now, in the presence of this somatic mutation, the anchor protein is lost, and all other proteins that are anchored in this anchor protein are not there. So the RBCs are devoid of these inhibitory molecules that are important to inhibit the complement pathway, leading to lysis of these blood cells. Now, these are the two important inhibitory molecules, CD55 and CD59. PK accelerating factor, CD55, and membrane inhibitory for the active lysis is CD39. Enough talking about complement. So let's see which patients do we really need to test for PNH. As it's an ultra-rare disease, the presentation is not pathognomonic. In patients present with fatigue and symptoms, and there is no unique symptom that tells you this is probably PNH. But patients who have Crohn's negative hemolysis are patients that need to be tested for PNH. Patients who have hemoglobinuria or renal dysfunction in addition to hemolysis need to be tested. Patients with bone marrow dysfunctions, those namely aplastic anemia, hypoplastic MDS, and patients who present with unexplained cytopenias. Thrombosis, not every patient with thrombosis need to be tested for PNH, but patients with thrombosis in unusual sites need to be tested, such as Barclay syndrome. PNH is well known to overlap with many diseases, but the most are aplastic anemia and myelodysplastic syndrome. In fact, 91% of patients who are diagnosed with PNH have some degree of cytopenia. The classic type that we diagnose patients with is hemolysis, thrombosis, and bone marrow failure. But it's known, and there is evidence that PNH clones are so common in the population, but they are very tiny. Most of the time, there is a second hit to the bone marrow that gives advantage to the small clone to overgrow and becomes the clone that leads to the problems of hemolysis of these RBCs. Now, when untreated, patients with PNH complain of these symptoms: fatigue, thrombotic advancement, hypertension, and otherwise. Now, a treatment we used to have in the past before any specific treatment comes into the market is usually antibiotics, blood transfusion, steroids, iron therapy for iron supplementation for some patients. But historically speaking, patients when treated only with supportive care, you can see the curve here that is looked at in the 1970s. 50% of the patients die within 10 years. Thanks God. Now, it's a very competitive landscape nowadays, and there is no hematology meeting without a PNH talk, mainly because of this circuit. There are too many drugs for this being developed or have already reached the market. There are already 6 molecules that are approved for PNH. You can see in the middle, these are the approved ones. There are 3 molecules that are targeting C5. There is pegylated, which is targeting C3. And there are 2 new oral molecules targeting factor D and factor B, mainly daniclopran and iptacopan. So let's start with C5 inhibitors. And these are the first molecules. That was the first molecule to be introduced to the market and approved in 2007. So what they do, they are antibodies that inhibit the action of C5 convertase on C5. Therefore, it prevents the formation of the membrane and complex that leads to lysis of these RBCs. Icabizumab was the first molecule, as I said, after the triumph and the Cellular trials, approved in 2007 as a specific treatment for PNH. It's usually given induction course 600 milligrams weekly for 4 weeks with 900 milligrams every 2 weeks. Ravulizumab is the second C5 inhibitor that came into the market from the same company. It's basically based on the icabizumab molecule. There has been a change in 4 residues that led to the prolongation of the half-life. You can see here that the half-life of ravulizumab is 49 days compared to 11 days for icabizumab. Now, these 2 molecules have been tested in two trials, 301 and 302. You can see here that with icabizumab there are variations in C5 inhibition, while with ravulizumab it's continuous. It did reduce hemolysis, and more than 90% of patients like ravulizumab because it's given every 8 weeks instead of 2 weeks. And it's better mainly in preventing breakthrough hemolysis. We are still with some C5 inhibition, terminal pathway inhibition. More recently, crovalimab has been developed. It was developed initially by a company called Shugai in China. And this company actually specializes in prolonging the half-life of antibodies by a mechanism called SMART, sequential monoclonal antibodies recycling technology. That is depicted here on the left-hand side, where the antibody is engulfed by the lysosome, and then C5 is liberated and degraded in the lysosome, while the antibody is recycled again and makes the action continuously. That's why the duration is given, and the injection is given every 4 weeks. Crovalimab was tested in 3 trials, the Commodore 1, Commodore 2, and Commodore 3. Commodore 1 tested crovalimab in comparison with icabizumab in patients who have been treated with icabizumab in the past, Commodore 2 in treatment-naive patients, and Commodore 3 in Chinese people who So it has been proven that crovalimab is not inferior to eculizumab in terms of efficacy and its convenience of given subcutaneously every 4 weeks. But the problem with C5 inhibitors is the development of extravascular hemolysis. As you can see here in this pathway, it is more interesting. So, I don't know. Something, anyhow. So, you remember I explained this. Now, the action in the alternative pathway that is continuously active, there is continuous formation of CPD. And when you block C5 down below, you have accumulation of CPD on RBCs, and that is opsonization of these RBCs that are engulfed in the reticular system by macrophages in the liver and spleen, leading to what is known as extravascular hemolysis. Therefore, around 80% of patients who are treated with C5 inhibitors suffer from anemic symptoms. In fact, about a quarter of patients remain transfusion dependent. This is a very good pathway to follow for patients who start C5 inhibitors to start with. So the first parameter we look at is LDH, and if it is reduced to let's say more than 1.5 upper limit of normal to 2 if patients are asymptomatic, so you continue. If it is still more than 1.5 and patients are symptomatic, so you consider dosing for breakthrough hemolysis. Now, if it is less than 1.5, the upper limit of normal, it depends on the hemoglobin level. If hemoglobin level is satisfactory, then you can just continue therapy with C5 inhibitors. Now, if hemoglobin level is low and patients have symptomatic anemia, you check the reticulocyte count. And if they are elevated, that means the most probable cause is extravascular hemolysis causing this anemia. Now, if the retic count is low, then this is an underproduction of RBCs related to the bone marrow failure associated with PNH, and that needs to be treated probably separately. The first proton inhibitor that came to the market is Proton, which is a CP inhibitor. It inhibits the complement pathway earlier, so to eliminate the extravascular hemolysis. It's given twice weekly, and it's a cyclic synthetic antibody. It was tested against eculizumab in the Pegasus trial, where there has been a 4-week running period followed by 14-16-week randomization between pegcetacoplan or eculizumab in patients who have been off therapy in the past. So this is what it shows. See the red curve at the top, this is the hemoglobin level. Baseline was 8.7 grams per deciliter, and then the run-in period of 4 weeks led to the improvement of hemoglobin to 11.9 in both, because everybody was on eculizumab and pegcetacoplan back then. And patients were randomized, and patients who continued in pegcetacoplan, the hemoglobin level remained stable, while patients who were shifted to eculizumab had a drop in their hemoglobin down to the level of 8 to the baseline. And then after 16 weeks, both groups were given pegcetacoplan, and there is an improvement in hemoglobin. So definitely it's an alternative choice in patients who suffer from extravascular hemolysis. It's just the way it's given subcutaneously twice a week. So imagine all the therapies. We have 2 new molecules, factor D inhibitor and factor B inhibitor. explain the alternative pathway. These two factors are extremely important in activation of the complement system in the alternative pathway. So factor D inhibitor, danicopan, inhibits factor D because it's needed to split factor B and leads to the activation of factor B in this combination with C3 and water. It's given as an add-on therapy to patients who have been already on C5 inhibitors, either eculizumab or ravulizumab. It's not given as a monotherapy. So it was tested in the alpha trial, where patients were randomized to either the addition of danicopan to C5 inhibitor or placebo for 12 weeks. Then patients who were in placebo were shifted to danicopan in addition to C5 inhibitors. And this is the hemoglobin rise since the randomization. Patients in the yellow curve are patients who have been given danicopan in addition to C5 inhibitor have increased their hemoglobin concentration to more than 2. You can see here that hemoglobin rise of more than 2 kilograms happened in almost 60% of patients, while it happened on 0% of patients who continued C5 inhibitors alone. It did reduce the transfusion avoidance by 82% of patients who need one transfusion compared to 38% who continued on C5 inhibitor. The last molecule I'm going to talk about is iptacopan. So iptacopan is an oral agent that inhibits factor B, which is important in activation of the alternative pathway, as I mentioned earlier. So it does inhibit factor B, therefore it inhibits it earlier. There is no continuous formation of CPB, therefore no more opsonization of RBCs, decreasing the extravascular hemolysis and inhibiting the cascade. So iptacopan was tested in 2 trials. The first one is Applying PNH trial, which is an open-label, randomized multicenter phase 3 trial, investigating iptacopan monotherapy in PNH patients who have been having residual mean hemoglobin concentration of less than 10. And patients were randomized to either oral iptacopan 200 mg twice a day, or continued as before randomization on C5 inhibitors, be it eculizumab or ravulizumab. This happened for 24 weeks, and then after the 24 weeks, patients who were C5 inhibitors were also switched to iptacopan continuation. These are the patient demographics between the 2 groups, more or less similar. There are no differences in terms of blood transfusion, mean hemoglobin concentration, which was 8.9 in both groups, and other parameters. Now, what has been observed in this trial, patients who were treated with iptacopan, 51 out of 60 patients have increased their hemoglobin concentration with more than 2 grams per deciliter, with a difference of more than 80% between being continuing on C5 inhibitors or having been treated with iptacopan. Hemoglobin level of more than 12 has been seen in about 70% of patients on iptacopan as compared to 1.8% in C5 inhibitors. Transfusion avoidance happened in more than 95% of patients on iptacopan, while in only 1% of patients who have continued C5 inhibitors. These are the curves. So the first 24 weeks, patients were randomized to either C5 inhibitors to continue their C5 inhibitor with an increased metabolism, and other patients, the other group receiving iptacopan. You can see the hemoglobin concentration here that has risen by a median of 3.35 as compared to the C5 inhibitors. After 24 weeks, all patients were given iptacopan, and those who have been switched have reached more or less similar levels of hemoglobin concentration. Now, breakthrough hemolysis happened in 2 patients out of the 62 patients in iptacopan, while it happened in 6 patients out of the 35 patients receiving anti-C5, with annualized ratio of 0.07 in the iptacopan arm compared to 0.67, which was statistically significant. Now, side effects, there is no alarms, but there are more headaches with iptacopan as compared to C5 inhibitors, some nausea and dizziness, which resolves by time. Serious adverse events were seen more commonly with C5 inhibitors as compared to iptacopan, as you can see here. Now, the other trial of iptacopan monotherapy is the APPOINT trial, and these are PNH treatment-naive patients that have been started from the get-go on iptacopan monotherapy 200 milligrams BID has been, as seen here, more than 2 gram increment of hemoglobin happened in most of the patients, and most than 60% of patients have their hemoglobin concentration more than 12. Transfusion avoidance happened in all patients, and this is the hemoglobin concentration from the beginning. You can see that the curve here is slightly different than the curve of hemoglobin of patients who have been treated with C5 inhibitors and shifted to iptacopan. The rise in hemoglobin was quicker, but here we need about 10 to 12 weeks for the hemoglobin concentration to reach its steady state of more than 12 grams in most of the patients. LDH level has been consistently in the normal limit, in the normal range. Again, side effects, nothing alarming. And so, this is the algorithm I mentioned in the beginning. It's extremely important to any patient that has been started on C5 inhibitors from the beginning to look at their LDH, to look at their anemia symptoms, the presence of extravascular hemolysis signified by low hemoglobin and high reticulocyte count. Patients with low reticulocyte count, meaning they have more marrow failure, meaning they need other forms of therapy to that more marrow. And in conclusion, PNH is basically a rare disease, and there is a plethora of treatments. Now, we have mentioned C5 inhibitors, we have mentioned C3 inhibitors, we have mentioned the oral therapy with factor B inhibitor iptacopan, and the oral therapy with factor B inhibitor danicopan, in addition to C5 inhibitors. But there are many coming into the market probably, and the small inhibitory RNAs, C5, C3, mannose-associated serine protease inhibitors, monoclonal antibodies, and again, this factor B, and gene therapy. And I'm not sure what we are going to do with all these molecules in the future. Probably there will be more treatment options and patients in PNH. With this, I conclude my talk. Thank you very much. Do we take questions? What shall we do?
Joanna, Zina's here. Let's start with the first question. As you mentioned, each meeting we have PNH talk, and now we have 5 or 3 drugs for PNH. Choose wisely.
Choose wisely, yes. And I have put the algorithm And most of the time we start with C5 inhibitors currently. There are options in patients who have extravascular hemolysis that is signified by persistent anemia and high red X count, where you need to have either some form of proximal inhibition, either the addition of venetoclax or shifting patients to either pixicabtagene or iptacopan. Now the choice is based on the availability of therapy, the accessibility, and the ease of taking medication. Venetoclax and iptacopan are oral agents, and this is the first time we have some oral agents. The iptacopan is peculiar because it's monotherapy, it's a pill, no need for injections, but only probably time will tell which is which. All right, thank you very much. There is one question here. Start at the top.
At the very mentioned PNH, maybe she could one more thing. At this point, will deal the basic as a plastic anemia or any point for C5 or C5 inhibitor?
I think
The patients are already developed.
patients with aplastic anemia.
Yes.
How do we do that?
Any point for this inhibitor or no point?
Now, patients with aplastic anemia that have PNH, it depends on the clone size, and usually when it's associated with aplastic anemia, the PNH clone is extremely high because usually the immune mechanisms that have led to the aplastic anemia affect the normal cells and give advantage to the PNH cells to overgrow, and usually the clone size is big. So you need to treat the PNH clone with C5 inhibitors, C3 inhibitor, whatever. You need to treat these patients for PNH. But the treatment for the aplastic anemia component goes with the treatment guidelines for aplastic anemia. Severe aplastic anemia, where ANC is that 200, for example, and young patients are candidates for transplant, and they are still. But transplanting patients purely for PNH is not advisable with the presence of therapy that can control these patients properly.
You mean the transplant for PNH is an option, but if little plastic anemia,
Unless,
it's an option.
yes, usually, unless these patients are refractory to multiple lines of therapy, and this is extremely rare. Most patients usually respond very well to common inhibitors that are present in the market. So it has PNH, classical PNH, let's say, no aplastic, no MDS, no transplant, unless in very, very few patients, because the outcome of these patients, people usually try to relate this to aplastic anemia. We know the outcome of aplastic anemia, allotransplant is excellent. But this is not the case in PNH. This has been looked at. I mean, they had more, they developed more complications as compared to aplastic anemia, and they may succumb to the treatment itself. So, patients with classical PNH, no transplant unless you are really pushing.
Thank you.
Thank you.
Thank you, Dr. Ayman. It was a great talk. PNH is a rare disease and a lot of medication out there. We will go to the second session. I'd like to invite our moderator, Dr. Firas Ferrer. Dr. Firas Ferrer is a hematologist and bone transplant consultant at King Faisal Specialist Hospital, Riyadh, and he is the president of Saudi Society of Blood Disorder. Dr. Yasser Aziz University, Jeddah, and Dr. Muhammad Sayyid, he is a pediatric hemato-oncologist at King Faisal Research Hospital, Medina, and myself, my name is Ziad Sheba. In this session, we will have a 3-minute speaker. Dr. Yasser, please.
First of all, I would like to congratulate Dr. Bihani and their team, the scientific and organizing committee for this excellent annual scientific event we have. It's a pleasure for me to introduce the first speaker of the presidential symposium, Professor Bradley from Pennsylvania, USA. Professor Bradley is a well-known radiation oncologist with over 25 years of experience, clinical and academic. He contributed significantly to the field. He published hundreds of peer-reviewed journals, and his area of expertise is mainly in lung cancer, radiology trials. We know the art of giving radiation therapy is to give a large dose of radiation to the tumor and protect the surrounding tissue. Professor Bradley will highlight the principles of proton therapy and the future of the flash radiation therapy. Professor Bradley, the floor is yours.
Thank you, Dr. Bahadur. It's my pleasure to be here. It's an honor to be invited to your conference. Thank you very much. This is my first time in Saudi Arabia. It's very beautiful. I was asked to speak on the principles of proton therapy, so this is an introduction to a kind of radiation called proton immunotherapy. I was also asked to speak about flash radiation therapy, which is a developing technology, a research developing technology. These are my disclosures. Our learning objectives are to describe the rationale for using proton immunotherapy, understand the potential role of proton therapy as a combined modality approach using systemic therapy, and also in radiation, and understand the potential of flash radiation therapy, specifically proton flash. Proton therapy in the United States has grown a lot. Currently, there are 45 active centers in the U.S., and 13 more are under construction. I found this on the website for a group called APT. It's a national organization in the U.S. for proton therapy. And it describes the difference between X-rays on your left and protons on your right. On the left, you can see in the model of the patient there that X-rays go all the way through the patient. Protons can stop just behind the tumor and not penetrate through the rest of the patient. So there's an advantage to proton beam therapy, which you can see visually there. One physics slide, please. So on the right is a depth dose curve for different types of radiation therapy. I don't know if the pointer works. It doesn't. So you can see the purple dashed line is X-ray therapy. It has a low penetrance that rises quickly. Let's say for a 6 UV beam, the maximum depth is about 1.5 centimeters. And then as the purple dashed line shows, it goes all the way through the patient. The red line is a proton line, so you can see it stops just beyond the patient. That is a sharp peak called a Bragg peak, where the energy from the radiation is positive. And then when we treat patients, we use what's called a spread out Bragg peak. That's the blue line. And the tumor sits right in the distal range of that, and the beam drops off after the tumor is treated, so there's no penetrance all the way through the patient. Protons have the same biological cell kill properties as The advantage is we have decreased dose to normal tissues and decreased side effects and less complications. We are better able to treat tumors close to critical organs. There's also the potential to increase radiation dose, as Dr. Proton said. One of the problems we encounter is that when we increase the dose, we get more side effects. So potentially protons are a way to alleviate that. And we can combine protons with other therapies more safely, like chemotherapy and immunotherapy. People often ask, what do we use protons for? This is pretty common across proton centers. This is how we use them at men, where we treat approximately 100 patients per day at our center with protons. And we treat roughly 120 to 140 patients per day with x-rays. It's in the same hallways in the same center. We use pencil beam scanning for every patient, and it's about 20% pediatric cancers, 14% thoracic cancers, and you can read, all different types of cancers, and it's basically chosen based on the patient's tumor location, tumor volume, and different characteristics of that cancer. At Penn, we are fortunate. We have 3 locations where we have protons. We call it hub and spoke. The main 5-room center is in Philadelphia. And we opened a center in New Jersey. It's 12 miles away. It's a single-room center 2 years ago. And at the same time, 2 years ago, we opened a center in west of Philadelphia in Lancaster. So we have, in the world's only hub and spoke proton model, where we have 3 different centers where we treat patients. This is what the room is, what the patient sees when they walk in the room. Our version of protons is with a company called IBA, and this is a therapist with a treatment machine. The patient lays on the couch, and then the entry rotates around the patient 360 degrees. There's imaging in the room, so each day before the patient's treated, we get what we call a cone beam CT scan to localize the tumor and see our target before we turn the beam. This is a cyclotron. It sits, and this cyclotron feeds each of our 5 rooms. So there's one beam line, the same beam line going to each of 5 rooms. That's what it looks like behind the door. Insurance in the United States may or may not cover protons depending on what the patient's diagnosis is. And we embarked about 10 years ago on a number of randomized trials comparing photons to proton beam radiation therapy. 2 of those trials were reported at our annual meeting this past year in Washington, D.C. One positive trial for patients with oropharyngeal cancer of the head and neck, and a negative trial in localized prostate cancer. There are much more data coming. Numerous trials are reported and recently closed for cancers including lung cancer, esophageal cancer, liver cancer, brain tumors, and others. There's a pragmatic trial in breast cancer that completed accrual, and we are still waiting on events for that to read out, and numerous others under design. Just to focus on what positive trials have occurred, favoring protons over photons. This is the first one, is the Stephen Frank trial, the randomized phase 3 trial. Oropharyngeal cancer was run out of MD Anderson, reported at this past ASTRO. There was a toxicity benefit to protons, and this is not reported yet, but there's also a survival benefit with protons in patients with oropharyngeal head and neck cancer compared to MRT. There's a trial in oncology disease where patients get craniospinal radiation with protons versus localized radiation in the area of the tumor with photons that have progression-free survival benefit in the CNS. Stephen Lynn has a phase 2 esophagus trial of MD Anderson that's positive, and there's also a small trial of lung cancer that's positive. We have a share of negative trials where protons are not better than photons, specifically on MRT, one in lung cancer, one in glioblastoma multiforme, and the most recent one in prostate cancer, showing protons and photons have similar effects in those studies. Our approach to evidence development at the University of Pennsylvania, well, in the U.S., protons are an FDA-approved technology, and they're not experimental. But we often want to do investigational studies as we evaluate different disease sites and combination approaches with chemotherapy. We partner with our payers or insurance companies to develop and enroll patients in clinical trials to answer clinical questions. We offer price parity between protons and photons to encourage the insurance company to accept patients on the trials and pay for their treatment, and encourages patients to enroll in clinical trials. We share data with our payers at annual meetings and reviews, and it reduces costs on our part in terms of insurance appeals, reduces the delay in treatment, and allows more rapid access to our trials. Combining chemotherapy and protons has an advantage. As we stated, outcomes with combined chemotherapy and radiation therapy can have increased with good performance status, or show an advantage in terms of survival and organ preservation if they're toxic. It's expensive increased toxicity with combined chemo and radiation, or chemo and immunotherapy and radiation. We have hypothesized that reducing the radiation dose in the organs at risk will reduce the toxicity when protons are combined with either chemotherapy or immunotherapy. And also, we can potentially increase the radiation therapy dose. This was a study at the University of Pennsylvania by a colleague named Brian Bauman, who looked at our database of patients treated with protons versus photons and showed that protons had a better less 90-day adverse events, and grade 2 and grade 3, and less decline in performance status compared to photons. And that was across all disease sites that were treated. Proton therapy is ripe for regional expansion. We call ourselves the Rocket Center of Proton Therapy, and we've been extremely successful. We've been in operation since 2010, and we're expanding our clinical indications in terms of what cancers we treat. We're a leading training center in proton therapy, and I have a few slides about that. We offer a lot of basic research, and I'll touch on that in terms of FLASH. And we're regionally expanding to show to our neighboring communities in the hub and spoke model. Single-room proton centers are now mainly what's sold in the U.S. Many people aren't living in multiple rooms, so you can buy a single-room center to put in alongside your linear accelerator-based center. Just to touch on our clinical education program, we offer a training program for centers across the world that are opening proton centers. This consists of introductory video modules based on the role, whether you're a physicist, a radiation oncologist, a therapist, etc. We offer on-site training at Penn. People come for a week, 2 weeks, a month to train with us, so they can take that knowledge back home and implement the technology. We also offer on-site customer support. Just because you leave in after being with us a month, we have a close tie, and we can help our colleagues across the world with questions about clinical cases. This is an example of the educational course someone might take. This is a week, different colors represent your time with a physicist, or myself, a radiation oncologist, or a centrist. We train professionals have come on the side to train, so we're very proud of that. I was asked to touch on flash radiation. I put radiation that's delivered at a faster dose rate than conventional radiation therapy. The dose rate is 40 to 60 gray per second. It's about 10,000 times faster than what you deliver normally. Flash can be either electrons, photons, or protons. Preclinical studies have shown that flash radiation reduces side effects in normal tissues, while at the same time being equally effective in terms of tumor kill. Why is it important? If broadly validated, it can revolutionize radiation therapy. Higher doses can be delivered more safely to tumors, or established doses can be given with reduced toxicity to critical organs. And can we reduce the number of treatments? Flash is probably given in fewer fractions, let's say up to 5 fractions instead of 30 fractions. That reduces the amount of time a patient needs to come to clinic and decreases the travel costs. It makes us more efficient. These two curves show efficacy of flash radiation therapy in green compared to standard radiation therapy in red. You get an equal tumor cell kill in animal models when you use flash versus conventional radiation, so it's equally effective. It doesn't spare tumor. Flash has treated a few humans on clinical trial. The FAST-01 trial was run out of the University of Cincinnati. I was an investigator in that study. We treated 10 patients with bone metastasis, just as a proof of principle to see that we can treat with flash, and that has been published in Journal Oncology, as you can see. It was a non-randomized trial. We gave 8 gray at a minimum dose of 40 gray per second to extremity bone metastasis, like let's say a humerus or a femur. We observed no greater, we had equal efficacy and no greater toxicity with flash. This is our project at Penn. We started roughly in July 2018, looking at the physics aspects of flash, looking at accurate dosimetry. Our biologists became involved, or we did biological validation experiments. We've got a whole team in radiation biology looking for a mechanism of action. And we started testing it in canine models roughly in September of 2019. Lots of mouse model work. Here's some mouse model work that shows the effects of flash. When you get whole abdomen radiation therapy, the curve on the left is 14 gray in a single fraction. You can see in blue if they're not radiated, what their survival is. If they're given standard radiation in red, you get quite a few deaths. When you're given flash radiation in green, you were able to spare the bowel and the mouse survive. When we divide that in the middle curve, if we divide that 14 gray into 2 pulses, we even see a little better flash effect in the green compared to normal or standard radiation in red. And then if you get the dose too high, let's say 18 gray in a single fraction, the mouse dies. So there is a window, therapeutic window, that you're able to see the flash effect. This is an example of slides of histology for pancreas cancer, when patients or mice were given whole abdomen radiation and a focal pancreas tumor. You can see on the top that the H&E shows the same, no treatment showed no intestinal fibrosis. SR stands for standard radiation, where you do see intestinal fibrosis. And FR stands for flash radiation, where we are able to spare the intestinal fibrosis. So we have histological proof that flash spares normal tissue. We started doing large animal studies to work out the feasibility for more complicated disease sites, like head and neck cancer, for example, to elucidate the mechanism of the flash effect and to define the safety mechanisms for treating patients. We wanted to perform end-to-end testing in a non-human clinical trial to work out the kinks of the new technology and work with our vendor to introduce it to the community. We wanted to make mistakes in animals before we moved to humans, and we've learned to develop the technology along the way. We treated dogs who had developed their own canine osteosarcomas of the extremity. We enrolled 29 dogs, randomized them to flash versus standard radiation therapy. We irradiated both the tumor and the normal tissue, and then a planned surgery occurred with a veterinary surgeon, where the leg was amputated 5 days later, and we were able to evaluate that. We've done phase 1 and 2 trials with 20 and 30 dogs. We've escalated radiation dose from 12 to 16, 20 to 24 gray, and looked at histopathology. We divided the number of fractions from 1 to 2 to 3 to see what the flash effects were within the tumor control sparing fractures and the results of the amputation. Then we planned additional trials in head and neck cancers. Dogs get oral cancers like oral melanomas that our veterinary medicine colleagues at the University of Pennsylvania will send the dogs for therapeutic treatment, and we're able to test flash as well. We're also pursuing something called conformal flash. The humans treated on clinical trials so far use something called shoot-through flash, which means the beam goes all the way through the patient. With conformal flash, on the bottom, you can see on the bottom set of slides that the radiation dose stops just beyond the tumor, which would be a huge advantage for flash. This is more complex because it requires some apertures to be used in the beam path, but it will increase our indications for the number of patients able to get flash. There's no radiation of tissues downstream, and we can use fewer beams, like 1 or 2 beams, to treat. This is a two-way collaboration and the software is done through research, and this is our team dealing with those conformal flash. This was about 6. Looking at current observations with flash, it looks like the dose threshold is 4 gray. You need to at least deliver 4 gray or more each fraction to see the flash effect. Thus, this is more like a stereotactic type delivery, where you deliver fewer fractions, and say up to 5 fractions. You avoid multi-field delivery and avoid the spread of low dose. And you have to have dose rate gets below 40 gray per second, we lose the flash effect. And it looks like as it goes from 40 gray per second to 60 gray per second to 100 gray per second, our flash effect is strong. This is all evolving. This is what the snout looks like coming out of the beam. The beam passes through a set of apertures to pull back and determine where the beam stops. So it stops just beyond the tumor. This is called a hedgehog device. It will be patient-specific, so each patient can have a hedgehog device to determine the depth for each beam that you use. Here's some examples of plans for head and neck cancer. On the right is an IMRT plan called VMAT. You can see the 4 gray dose goes everywhere, versus a flash proton plan, we're able to treat the oropharyngeal cancer and miss the contralateral carotid and miss the contralateral subunit in this case. You can see much reduced dose distribution. This is the same patient, just looking at VMAT versus a flash proton plan. This is a 15 gray dose cutoff, so it's similar to the 15 gray dose cutoff. Develops today is successful implementation of this pencil beam scanning in this software called RayStation. Our plan quality seems very good. We have a single field multi-fraction planning that will be used in our first cases, and we are working with our vendors to submit an application to the FDA existing oral cancers were sent to us for treatment. We successfully treated 3 dogs who all tumors all regressed and were followed in those dogs and tumor toxicity. This is our dog trial for head and neck cancer. It's a 3x3 design. They were open to dogs with biopsy confirmed non-metastatic cancers of the head and neck. They were treated with pencil beam scanning flash, either shoot through or conformal. Primary endpoints were normal tissue toxicity and tumor response up to 8 weeks. And they're going to be followed for toxicity for 1.5 years. We've given 8 grade single dose. Each of those are 2 fractions. Sorry, we've given 8 grade times 2 fractions with shoot through, 8 grade times 2 fractions with spread out deep conformal, and then 12 grade per fraction times 2 fractions. We developed a flash kit that can be installed on 98 units in a Proton pantry so others can use it, let's say at the University of Washington or other centers with the same technology. We're working with IAA to obtain FDA approval for this. We continue to define technical parameters and performing clinical trials in large animals in the coming months. And we have written a human trial for patients with recurrent head and neck cancer, previously irradiated head and neck cancer, that will open in the 3rd quarter of this year using flash. One thing, the key learnings. The flash effect is real and has been demonstrated in any way where it's used, either electrons, photons, or protons. Flash shows normal tissue protection. Flash shows at least similar tumor control. I didn't show you the data, but it looks like the stem cells are spared with flash compared to X-ray based treatment. Dosimetry and the control of beam are critical to see the flash effect. Small changes in the beam can negate the flash effect. The flash effect is lost when we reduce the dose rate below 40 gray per second. And flash proton beam has the potential to be a major disruptor in oncology care. This is our team. There's many people involved in this. I'm just one spokesperson today. Thank you. Thank you for having me.
So we're moving to the next speaker, and we'll be switching to our very well. So we have Dr. Bashir. Dr. Bashir is Associate Professor of Clinical Oncology from University. He's spearheading several clinical trials in top in solid malignancy. And he was the addition of this topic in the next decade.
Hello, good evening. Thank you to the organizing committee for the kind invitation for me to present at this forum. My name is Dr. Bashir. I'm Associate Professor of Medical Oncology and Oncology at Jefferson University in Philadelphia, USA. The topic of my talk is CAR T-cell therapy in solid tumors. These are my disclosures. So we're going to achieve through this talk a few learning objectives, and we're going to discuss briefly regulation of tumor immunity, mechanism of CAR T-cell therapies, types of cellular therapies. I'm going to give you some examples of separation of CAR T therapies, particularly in the context of cancers, and something we're developing at Jefferson. We're going to discuss the limitations of CAR T-cell therapies in solid tumors and how we strategize to overcome these, and some future direction, particularly off-the-shelf like PSC-derived cellular therapies in solid tumors and in vivo CAR T therapies. As you know, the tumor immunity is a complicated, very rigorously controlled mechanism. Our immune cells are driven to the tumor microenvironment using the chemokine gradient. The chemokines are listed here. Once inside the tumor microenvironment, we hope that some of the tumor cells undergo apoptosis and release cancer antigens. Now, these cancer antigens will be taken up by type of cells called antigen-presenting cells, particularly dendritic cells in this example. These antigens are taken up by the ADCs and are degraded using fatal lysosomal degradation into small 8 to 10 amino acid mers. These antigen peptides, called epitopes, are then expressed on the surface of major histocompatibility complex 1. MHC1 molecules are expressed on the surface of the dendritic cells. Now, these loaded dendritic cells are then turned into the secondary lymph node organs, for example, lymph nodes, and these antigen-loaded dendritic cells then result in activation of T cells. In this example, using the MHC1 loaded peptide, it will interact with the TCR receptor on the CD8 T cells, as well as MHC2 complex will drive activation of CD4 T cells, and using various cytokines, there is activation of these T cells. Once activated, these T cells we hope will travel back into the tumor microenvironment using the same chemokine gradient, and they will result in active lysis of the cancer cells. Another aspect of regulation of tumor immunity is the role of tertiary structures. Here, for T cells, plasma cells, and B cells. So all in all, this is a very highly mechanism. When we think about therapies like solid tumors, it's really important that we keep this in mind. Now, in a very simplified version, what is CAR T-cell therapy? It is patient-derived product, as well as a product collected using the process of leukapheresis. In a cancer patient who undergoes leukapheresis, we isolate the T cells and activate them, and then convert into CAR T cells using a transgenic delivery of a construct construct using the antigen delivery system. Now, this construct has basically three features: one, extracellular single-chain fragment to our antigen of interest. It has costimulatory molecules like proton and CD28 that are required for activation of the CAR, and an intracellulary CD3 zeta, which will activate intracellular machinery of the T cells upon engagement of the CAR receptor. Once constructed, the primary antigen receptor T cell has an ability to recognize surface antigen on cancer cells, and this is expanded ex vivo, meaning multiple copies of these are expanded using two other cytokines, and once we have a sufficiently high dose of CAR T-cell product, it is released back into the patient, anticipation to exert its therapeutic effect. Now, there are different types of CAR T therapies. The most common, the one we're going to talk about today is the chimeric antigen-receptor T-cell therapy. We alluded to the mechanism, but there is something called chemotherapy or chemotherapy lymphocytes therapy. Here, tumor cells are excised from the patient, and naked natural T cells that are already in an active state are isolated and expanded ex vivo and infused back to the patient. There's another type of cell therapy called TCR therapy. Unlike CAR T therapy, here we transfuse a cancer-specific T cell receptor, where this T cell receptor only has the ability to identify a cancer epitope in the context of an appropriate MHC class 1 or class 2 molecule. So the application of TCR therapy is not as widespread as it would be for CAR T cell therapy. Very recently, we have also seen a lot of activity in instead of using adaptive immune cells like T cells, using innate immune cells like NK cells or macrophages or monocytes. Now, the interest in this type of therapy is driven by the extensive inhibitory tumor microenvironment in solid tumors and the targets that using T cell macrophage or monocyte CAR therapy would be beneficial. Now, adaptive cell therapies has seen many successes, mostly in blood cancers, particularly for B-cell malignancies against CD19, antigen, for examples are listed here. For B-cell malignancies, particularly for multiple myeloma, BCMA CAR T therapies have been approved. For solid tumors, we do not have CAR T cell therapy approval yet. However, we have some very recent approval of two therapies for cutaneous melanoma and a PCR-T therapy called Femstel for synovial sarcoma that targets MAGE4. Now remember, this only applies to a very specific HLA type. The patient must have the co-expression of the required HLA for this therapy to work. Now, with solid cancers, the trouble has been that we know what the antigens are, but we have seen significant toxicity. For example, in colorectal cancer, we have observed death using other CAR T therapy, severe colitis using the CEA, TCR-T therapy, and other examples are listed here. If you see across the globe, unlike heme CAR T therapies, solid tumor CAR Ts are not as abundant available, but the field is ripe with new excitements and new approvals coming along. Now, when we talk about target antigens for CAR T cell therapies, I think one of the key points we want to make here is you can use new antigens or you can use shared tumor antigens. Now, new antigens would be ideal, and we actually have started seeing some of the leading experts in this field using tumor-specific mutations like KRAS G12D and developing CAR T or TCR-T therapies against these antigens. The natural advantage of using new antigens is that because they are not shared with the normal cells, you will not see as much off-tumor or on-target toxicity. Now, shared tumor antigens must be used, and I'll explain why I think that. The shared tumor antigens can be self-antigens or non-self-antigens. If we think about self-antigens, cancer-testis antigens, for example, MAGE, and Cellular, prime examples, differentiation antigens like tyrosinase, G100, UC2C, PSA, overexpressed antigens like PRAME, HER2, GIC3, and some of the non-self antigens are, for example, those derived from human papillomavirus, E6 and E7 protein. Now, when we think about the targets in the context of solid tumors, as you can see, not a lot of solid tumors produce abundant variety of new antigens, with the exception of maybe cutaneous melanoma and this mentioned deficient colorectal cancer. The majority of solid tumors do not produce a lot of new antigens, which is why we think that normal but overexpressed self-antigens must be part of the equation when thinking about developing CAR T therapies for appropriate cellular targets on cancer cells. Now, the self-antigen targets are exciting. CD19, for example, is a self-antigen. It's normally present on B cells. When we develop CAR T therapy, we're developing ideally against that same antigen expressed on the cancer cells, where the normal antigen expressed on the normal B cell will also be compromised. In this example, we use CD19. While the CAR T therapies will eliminate B cells, causing immunodeficiency and other problems, we still use it in the context of hematologic cancers because these are conditions that we can easily manage. But when we think about self-antigen in the context of solid tumors, the toxicity profile may be too high. And that is actually evident from a recent example using a mesothelin CAR T cell therapy. This was recently published. Cell therapy is a mesothelin targeting CAR T cell therapy. As you can see across various solid tumors, including malignant with this CAR T therapy, significant regression of the tumor. But the problem is mesothelin is a monocyte antigen and is also expressed on the mesothelial cells, particularly in the pleural cavity. So in these examples, a couple of patients develop on-target toxicity, resulting in severe pneumonitis and causing significant problems for those patients. Now, when we think about self-antigens, one of the things that we are trying to develop at our institution is using the concept of our compartmentalized antigens. Now, compartmentalized antigens are self-antigens for CAR T therapies, which are accessible on the tumor cells, like CAR T cells, however, they are not accessible in the normal cells. Why do cancer cells and normal cells become compartmentalized? I will illustrate if we have an example. So the idea here is if we can keep CAR T cells separated from the antigen on the normal cell, then we have probably achieved a very good therapeutic index and maybe limited toxicities in the CAR T cell therapies. So in this example, I'm going to discuss some of the lab discoveries at our institution that we have been working on called institution-directed CAR T therapy. Monocyte C or GCC, as I will illustrate later on in this slide, is an intestinal receptor that's required for intestinal homeostasis. Upon activation by its cognate ligand called globulin, results in activation of GMP. Now, if you think about colorectal cancer, normal epithelium of the colon has abundant expression of monocyte C, so it is a self-antigen. However, in the context of cancer, monocyte C is also overexpressed in cancer cells, and not only in the primary tumors, it's also overexpressed in metastases, including in the liver and in the lung. So we think it's an overexpressed antigen, but it's a self-antigen. So when we think about the concept of compartmentalization, this is what I mean. Normal intestinal cells have what we call very tight junctions that tethers the entire intestinal epithelium together, and this is done naturally to prevent any intake of bacteria in the intestinal tract or viruses or other environmental toxins that we ingest. But one of the natural advantage of this tight junction of compartmentalization is that when we have CAR T cell therapy, CAR T cell therapy will remain in the outside of the lunar interface of the intestinal mucosa, and the GCC will be shielded from attack by the CAR T cell therapies because it's only expressed on the apical surface facing the intestinal mucosa. Now, when these cancer cells, colon cancer cells, become metastasized, obviously they lose this polarity, so they are no longer compartmentalized in the metastatic state. And so, in order to test our hypothesis, we developed syngeneic models of GCC CAR T therapies using two different shaped variable fragments called MS7 and MS24. We saw significant lysis in our animal models using MS24, GCC CAR T therapies, and we also saw elimination of metastatic deposits in the animal models and those in the soil. So what about toxicity? Because GCC is expressed in normal epithelium, so we were very interested in looking at any clinical or histological evidence of toxicity from CAR T therapies in a mouse model. And we looked across various tissue types, small intestine, colon, using normal control area versus MS24, and we actually saw no evidence of toxicity, including some of the major organs like brain, lung, liver, heart, and kidney. Now, we need to test this in the context of human models, so we developed GCC CAR T therapies against human GCC, and we used that in vivo experiments. In vivo experiments, we saw significant lysis using GCC CAR T therapies, and we also saw patient-derived xenograft models and improved survival in that context. Now, this is very, very promising, both in the context of colorectal cancers, but let's talk outside of There is a concept in which cancers called intestinal metaplasia. As we know, the normal esophagus epithelium is described by squamous epithelium, but when these tissue organs develop adenocarcinomas, they get transformed into columnar epithelium concept, very closely resembling the epithelium in the normal colon, the concept called intestinal metaplasia. Now, we think when these cells undergo this intestinal metaplasia, they also acquire GCC during this transformation. So GCC may also be overexpressed in these tumor types. And indeed, when we look at the expression profile of GCC in esophagus, adenocarcinomas, we saw significant increased expression compared to the normal esophagus. And this is why we think that GCC may be also a very relevant target for esophageal, gastric, and gastroesophageal adenocarcinomas. We did some work in the PDX model for patients with the help of our surgical colleagues in the institution. We developed the PDX models in urinary models and used control versus GCC feeds, and we saw significant reduction in tumor volume on these PDX models and the survival longer. Same is true for gastric and esophageal adenocarcinomas. Now we are in the process of bringing this discovery to our patients. So right now we're in the process of establishing a GMP CAR-T production at our institution, hoping to recapitulate the findings that we saw in the animal models and ultimately develop a autologous product that we can infuse to our patients and hopefully help. Now, I want to switch gears and tell you why CAR-T therapies have not been super successful in solid tumors. There are some limitations when you think about CAR-T therapies in solid tumors. Unlike hemolignancies, where the cancer cells exist in the blood space, the CAR-T cells are given to the blood space and they can directly interact with each other. Unfortunately, in solid tumors, the CAR-T therapies have to infiltrate the tumor microenvironment. And one of the problem may be that instead of going into the tumor, the CAR-T cells may be misdirected to go into the secondary lymphoid organs, which is not going to be the place where they can exert their effect. And one of the problems is that they may lack the adhesion receptors required for the successful delivery of the CAR-T cells into the tumor microenvironment. There may be significant chemokine mismatch. The autologous T cells will not have the chemokine receptors required to infiltrate the tumor microenvironment. And in general, the solid tumor microenvironment has also called extracellular matrix barriers, like a lot of fibroblasts and stromal fiber cells that limit the penetration of the T cells. Another important escape mechanism is cancer cells can learn to escape and lose the antigen. So we all CAR-T cells have a specific antigen. Cancer cells know there is a primary T cell target that antigen, and cells will decide to disengage from that antigen. CAR-T cell therapy in some tumors can also use on-target off-tumor toxicity, like our example with the mesothelin CAR-T, and generally, they can also produce other toxicities that we know already. Now, how do we strategize to address these limitations in solid tumors? We can custom modify the CAR-T cells to have the chemokine receptors that are necessary for successful trafficking into the tumor microenvironment. We can engage these CAR-T cell therapies in the lab and producing them in costimulatory domains or chemokine receptors to enhance their proliferation and survival. Instead of using cancer antigens, we can use very specific antigens that are only expressed in the context of cancer and hormone cells, so enhanced tumor recognition. There is some interesting work going on with gated CAR-T cell therapy or low-target CAR-T cell therapies. And how do we control? We can limit toxicities by making the drug usable self-destruct rather than the CAR-T therapies. For example, EGFR protein is overexpressed, and when these cells are given these tissues that can stuximab, for example, it can turn off the CAR-T cell therapies and that can result several of the setbacks. Some of the other strategies are to overcome this aggressive tumor microenvironment using CRISPR-Cas9 expression of PD-1 and CTLA-4, and some switch receptors, or something called TRUX, which is mutated cytokines that can further enhance the activity of CAR T therapies. Now, in terms of the design features, we have also understood that maybe using a target with better specificity would be the key to successful CAR T therapies. Maybe instead of using a low cutoff for target antigen, using a high cutoff and maybe target enrichment. Instead of using CAR T therapies, at least one antigen, maybe we should use dual target CARs. There are strategies to improve the affinity of single-chain variable fragments, where one to this target antigen more strongly. So the concept are called synapse receptor, where the T cells does not exist, CAR T cell does not exist in an activated state. On activation to a receptor, it gets converted into the CAR, so it's a two-step activation process. And then we can block some of the inhibitory cytokines, particularly TGF-beta, which has a very promiscuous role in causing immunosuppression. We can also use armored CARs, where they have cytokine loaded, released, and some of the strategies are working towards developing CAR T cell therapies to prevent T cell exhaustion. So I want to give you a couple of examples. So Cellular, or CT041, is a humanized Claudin 18.2 redirected CAR T therapy. Now, Claudin 18.2 is a pan-cancer target. It's expressed in multiple epithelial tumors, but very highly expressed in gastric cancer and gastroesophageal junction tissues. CT041 is a patient-derived autologous CAR T product that has a CD8 alpha and CD28 transmembrane region and CD3 activation domain. Now, in the phase 1 study design, they enrolled patients aged 18 to 75 who had been previously treated with multiple lines of therapies, and all these patients were selected based upon high expression of Claudin 18.2 on their archival tissue. After identifying these patients, we were doing cell collection and manufacturing, and ultimately resulting in infusion of the sector cells by T cell therapy. Now, the initial look at the efficacy of the phase 1 data was very encouraging. This therapy is very effective. Indeed, it produced a significant reduction in the volume of tumor in the patients that it was given with an objective response rate of 48.6% and a disease control rate of 73%. At recommended phase 2 dose, this was further expanded to patients who have been treated with more than or equal to 2 prior lines of therapies for gastric cancer. And in this enriched patient population, the objective response rate was 61%, disease control rate was 83%, median progression-free survival of 5.6 months, and median overall survival of 9.5 months. Patients who responded with a median duration of response was 6.4 months. Now, this is an example from the same paper. This was a patient who had gastric cancer with peritoneal metastasis and cistern Joseph nodule, had received 3 prior lines of therapies, including checkpoint inhibitors, and after treatment with the cellular cell therapy, they achieved partial response, and the patient had ongoing response more than 56 weeks. Now, this patient was target enriched. They had very high expression of Claudin 18.2, indicating 80% of the cancer cells had high expression. Now, there was a press release from Oncology, which is a company developing this CAR T therapy, that they have achieved positive top-line results from China in their pivotal phase 2 clinical trial. The data is not available, but we hope to see some exciting news from that data. Another example of CAR T therapy using dual armored CAR is the CCAR031. This is a GPC-directed TGF-beta receptor 2 dominant negative armored CAR T. GPC3 or Glucocan-3 is an ideal target for hepatocellular carcinoma. It's highly overexpressed in the majority of HCC patients and virtually absent in normal adult cells. Now, CCAR031 has an affinity-enhanced anti-GPC3 receptor, so it binds to the GPC3 on the surface of cancer cells, but it also has a full expression of TGF-beta receptor 2 dominant negative, what it does, it captures and prevents TGF-beta-driven immune suppression. So indeed, this was not the first time GPC3 targeting CAR has been tested in humans. The previous iteration of GPC3 CAR T therapy that resulted in an objective response rate of 15 to 15%. However, in this study, it demonstrated an objective response rate of 50%. So that kind of alludes to the importance of overcoming the suppressive tumor microenvironment using TGF-beta receptor predominant negative. Now, this was a particularly toxic therapy. 92% of the patients had cytokine majority of that was grade 1, grade 2, only 4% was grade 3, and this results had led AstraZeneca to conduct its ongoing phase 1B study called Proton. Now, how do we overcome manufacturing hurdles? Because one of the things with solid tumors is patients, unfortunately, when they're progressing really rapidly, and maybe not everybody has time to wait for a 4 to 6 week manufacturing of their autologous products. So there's been a lot of excitement in this field. One of the strategies we use what we call IPSC, off-the-shelf CAR Ts, and the third exciting area is in vivo CAR Ts. Now, off-the-shelf CAR T therapies is a very complicated process, but indeed, it starts with collection of induced pluripotent stem cells from a healthy donor, where these cells are cloned, selected, and banned, and undergo lineage differentiation into maybe inducible NK cells or inducible T cells. Now, these inducible T cells are then converted into CAR T cells by incorporation of a chimeric antigen receptor against a particular antigen. Now, in this example, Fate Therapeutics is developing, or it has an ongoing phase 1 study of a HER2-directed CAR T cell therapy. And one of the exciting things with this approach is that you can modify these T cells from allogeneic source to then co-express other things. For example, they have expression of CXCR2, which is the chemokine receptor, so it will enhance the penetration of the CAR T into the tumor microenvironment. It has TGF-beta suppression, and it knocks out CD38 and TCR to prevent graft versus host disease. Then they can also incorporate in HNC16 that then becomes a decoy receptor for antibody-dependent cell-mediated cytotoxicity, and these CAR T therapies are given in combination with monoclonal antibodies like cetuximab. So that's the off-the-shelf CAR T therapies. Another avenue is in vivo CAR T therapies. Now, this is a very exciting field. In the left-hand figure, as you can see, ex vivo CAR T therapy, you collect the cells from the patient, they get into fast gene delivery outside in a very controlled laboratory environment, and then these cells are infused back into the patient, and they do what they do in the context of all these patients must receive lymphodepletion chemotherapy prior to that. Now, in vivo CAR T therapy uses very specific delivery vehicles using some of the viral vectors or maybe some of the nanocarriers that directly infuse to a cancer patient, and they will result in situ expression of CAR T therapies in the T cells within a patient, and hopefully those T cells will become engaged with the tumor cells and result in tumor cell kill. Now, when we think about pros and cons of in vivo CAR T therapies, obviously, it will eliminate the need of manufacturing. So it will be a very fast-speed process. It will generate CAR T cells in vivo. It will be very beneficial in terms of cost and accessibility. These patients will require lymphodepletion chemotherapy. However, the problem right now is that there's no real mechanism known to us to control the delivery of the carriers inside tumor T cells. How do we control the cell fate? Whether they get transformed into something that we not intend around the same. So all these things, hopefully, once we see some of the data from one of the phase 1 studies, will clarify for us. So I know we covered a lot. So in summary, solid tumor CAR Ts are becoming a reality. We still do not have an FDA approval yet. We've seen encouraging activity with Claudin 18.2 multiple trials are enrolling across all tumor indications. There's several strategies to improve therapeutic index of CAR T therapies, for example, target compartmentalization and enrichment, as we discussed an example of CARs. There are various means and ways to enhance the design of CAR constructs. Maybe CAR T therapies shouldn't be used alone, they can be used in combination checkpoint inhibitors or RNA vaccines. And we have gotten better in mitigating some of the toxicities. Exciting future innovations on our shelf are IPC-derived CAR T therapies and in vivo CAR T therapies. So I thank you for your attention and look forward to our panel discussion later. Yes, I can hear you.
So because you are with us online, we'll take a question for this talk. So for the audience, any questions for CAR T cell and solid tumor? If no question, we'll take the first one. So, Rob, what do you think about the difference between what we are doing in, let's say, lymphoma or acute lymphoblastic leukemia and CAR T cell? We know it's not FDA approved, but what is the feasibility and how practice is that? Especially if we have to give a gap or period between the CAR T and the chemotherapy.
Yes, so great question. So I think part of the problem with comparing CAR T therapies and solid tumors and lymphomas is the compartment that the proteins need to enter. The tumor microenvironment, as we discussed during the talk, is a very immunosuppressive environment and a lot of protein concerns. Nothing to get into the area, a lot of new exciting things happening as we've heard. From some of the genetic-focused CAR T trials were definitely a success. So I think, we're not very far away from an approval for CAR T therapies in solid tumors. We recently had a PCR T therapy for sarcoma, which was a very, very lengthy process to approve these patients. But I think, we're witnessing some successes. And one of the problems with CAR Ts is, unlike lymphomas, where you can target CD19 or CD20 and don't care about avoid deficiency or immunodeficiency as a consequence. A lot of antigens in solid tumors, with these therapies can result in very significant toxicities in humans. So, for example, as we saw the mesothelin CAR Ts, there's significant monoaminitis, which becomes a very limiting step in the chemo development. But I think with the target enrichment and target specialization, we will see some improved therapeutic benefits.
Thank you. Any questions? So my last question would be, what about the financial toxicity? And when you will consider the CAR T cell in the cascade?
Yeah, that is a great question. So I would say right now, because every CAR T therapy is being given in the context of clinical trials and everything is kind of covered, but eventually when you have approvals, I think that would be a very important question how to sequence these therapies and when to consider CAR T therapies really, I think that would be the next avenue of research and have a lot to think about. CAR T therapies are not cheap. They require a lot of manufacturing hurdles and everything has to be a Rolodex has to fall in place for these to be successfully developed. I think, a lot of times this would be in relapse refractory setting once we have a role, but once, we demonstrate efficacy, why we want to keep it in that space, we have to move it up because, ultimately the goal is to move survival for our stage 4 cancer patients.
Thank you so much, Dr. Bashir, and hopefully we'll have you physically next year in Saudi Arabia.
Thank you for having me.
Good evening, everyone. It's my sincere pleasure to introduce Dr. Stephen Henkel, one of the greatest leaders in the world of the pediatric oncology. Dr. Henkel is globally known for his work in childhood leukemia, with extensive work contribution in both clinical and translational research. Dr. Henkel holds the Jeffrey Berman Distinguished Chair in Pediatric, and he is the Pediatric Oncology Division Chief and Director of the Childhood Cancer Research Center at the Children's Hospital of Philadelphia. Dr. Henkel also is a professor of pediatric and Associate Director of the Pediatric Cancer Center at Berman School of Medicine, University of Pennsylvania. Steve has been at the forefront for advancing leukemia treatment, particularly the development and application of immunotherapies. With decades of experience, Dr. Henkel has played a key role in improving outcomes for children with leukemia through our groundbreaking research, collaborative leadership, and deep commitment to patient care. Today, he is here to share with us the latest advances in leukemia, immunotherapy, an area that is rapidly transforming the way we are treating this challenging disease. Please join me in welcoming Dr. Stephen Henkel.
Thank you for that very kind introduction. I'd like to thank the organizers for inviting me to the meeting. It's always a pleasure to be in the kingdom and to visit Medina. Is there a way to see the slides on the screen? Okay, my disclosures are as listed here. Childhood acute lymphoblastic leukemia is the most common malignancy in children, and this has gone from a disease that was incurable in the mid-1960s to one with a cure rate is in the range of 90% recently. However, as you can see from this slide, the rate of improvement seems to plateau over time. Now, this is a list of the drugs used to treat pediatric ALL, and all of them have been available and used in the clinic since the mid to late 1970s, and we saw the improvements since that time. So most of the improvements we've seen are not due to the development of better drugs, but rather to using the drugs we've had more effectively. I'm first going to start by talking about relapse ALL. I showed you the nice outcomes for newly diagnosed ALL a short time ago, but the outcomes following relapse are nowhere near as good. And this is a study published recently that looked at over 16, it started with a study set of over 16,000 patients enrolled in frontline children's oncology group ALL trials. Of those, about 13%, or slightly over 2,000, relapsed. And this graph shows their survival after relapse. Now, we don't know the exact details of the therapy they received, but given the era, it was most likely chemotherapy with or without allogeneic stem cell transplant. And here you can see that overall, slightly less than half are long-term survivors, somewhat better for late-age ALL than teen-age ALL, and much worse for infants with ALL. And this looks at a little of the predictors of outcome post-relapse. So here we define the time to relapse on the left left-hand side, so early is defined as less than 18 months, which is on therapy. And here you can see the survival is about 25% of those patients. In contrast, the patients with a late relapse, which means more than 36 months, have a survival of about 2/3 or 66%. And those with an intermediate time relapse have an intermediate outcome. On the right-hand side, we look at the site of relapse. So the most common site of relapse is isolated bone marrow relapse, and there we have about 45% long-term survival. In contrast, patients with an isolated central nervous system relapse have about a 66% long-term survival rate. Now we know that cytogenetics are predictive of outcome at the time of initial diagnosis, but until recently we haven't had a robust enough data set to look and see whether this is predictive of outcome following relapse. This slide shows us several things. First, the main two favorable cytogenetic abnormalities at initial diagnosis are ETB6 chromosome 1 fusion, or simultaneous trisomies of chromosome 4 and 10. And those are also predictive of a favorable outcome at the time of relapse. These patients tend to relapse late, with a median time of relapse of 43 months. And we see that their survival rate is 70 to 75%. In contrast, we have some other genetic subtypes, hypoglykemia, rearrangements of the KMT2A gene, and TCF3-PDX1 fusion. From the 119 translocation, these patients have a short median time to relapse, like 12 to 18 months, and poor survival, and worse survival, being with patients with hypoglykemia only 14%. I'm going to spend, there are several new immunotherapies available to treat all, but in the interest of time, I'm going to focus on blinatumomab tonight. So blinatumomab is a so-called bispecific T-cell engaging antibody, or BiTE antibody, and it's really a two-sided monoclonal antibody. One side recognizes CD3 expressed on the surface of normal T-cells, and the other side expresses the antibody recognizes CD19, which is expressed on all malignant B-ALL cells, also normal B cells. And so what this does is this antibody brings the T cells to the patient's CD19 positive cells, be they leukemia cells or normal cells, and allows cytotoxic killing of the cells. The drug has a very short half-life, so the current formulation is given by a continuous 28-day infusion. And it has side effect profiles that are very different from what we're used to with cytotoxic chemotherapy, with very little neutropenia, thrombocytopenia, or anemia, and no mucositis, so you don't tend to see infectious toxicity, and very low incidence of serious infections. But it does have some unique central nervous system toxicities, including seizures, malformation in some cases, and hallucinations. Blinatumomab was first developed now over 15 years ago and started to enter clinical trials about 15 years ago, 10 to 15 years ago. And early studies showed safety and efficacy in adults initially with relapsed and refractory ALL, and later in children with relapsed and refractory ALL. The initial pivotal phase 2 study showed complete remission rate, or complete remission rate with incomplete count recovery of 43%, and a median overall survival of 6 months in adults with relapsed and refractory ALL. These actually are very good results. And this led to a pivotal phase 3 trial, eventually published by Dr. Katarjan in the New England Journal of Medicine, randomized adults with relapsed and refractory ALL received either 128-day cycle of blinatumomab or a cycle of intensive chemotherapy. Blinatumomab is associated with significant increase in remission rate, 6-month event-free survival, and median overall survival of 7.5 versus 4 months. This study led to the FDA approval of blinatumomab in the United States, followed by approval in the EMA. They also laid the foundation for multiple additional trials of blinatumomab in both pediatric and adult ALL. And I think we So this was first done in pediatrics in children with first relapse of PNH. And just a quick summary of how we classify and treat relapse PNH in pediatrics. First, the Children's Oncology group uses various risk categories based on the time to relapse and site of relapse. So for bone marrow relapse, higher risk for patients who relapse early, within 36 months. Intermediate risk, low risk, are patients with late relapse, more than 36 months after initial diagnosis, who are minimal residual disease, negative at a level of 0.1% after 1 month of induction chemotherapy. Intermediate risk patients are those with a late relapse who are MRD positive after a month of therapy. And the general therapeutic strategies pursued in these settings for high and intermediate risk relapse patients are to get them into a solid remission, ideally MRD negative with good function, and then pursue allogeneic hematopoietic stem cell transplant. In contrast, patients with a low-risk relapse are typically treated with 2 years of chemotherapy without hematopoietic stem cell transplant. So I'm going to spend a little time talking about the Children's Oncology Group AAL1331 clinical trial, the overall design of which is depicted here, and this is for patients with first relapse of PNH. All patients receive 4 weeks of intensive chemotherapy, and then we're risk classified into different groups. I'm first going to talk about the higher risk randomization. So again, all patients receive a block of intensive chemotherapy. It's based on the UKAL R3 regimen, as shown there. And at the end of that, they were risk assigned to different groups. Patients with treatment failure were those who did not enter remissions who still had an M3 marrow greater than 25% class. I'm going to talk more about these patients other than to say that their outcome was poor. In contrast to low-risk patients, again, those with a late, isolated, combined bone marrow relapse who are MRD less than 0.1% of negative reduction, or those with isolated central nervous, isolated extramedullary relapse, more than 18 months after initial diagnosis, are classified as low risk. High-risk patients were the early relapses, as I said, relapsing within 36 months of initial diagnosis, or an isolated extramedullary relapse within 18 months of initial diagnosis. And the intermediate risk were the late relapse patients who were MRD greater than 0.1% at the end of the first month of therapy. The high risk and intermediate risk together participated in a higher risk randomization. This depicts that randomization. Again, patients all received 1 month of chemotherapy, and then were randomized. Arm A, the control arm, they received 2 cycles of chemotherapy based on the UKAL3 regimen again. And Arm B, the experimental arm, received 2 28-day cycles of blinatumomab. The goal then was for all patients to go to hematopoietic stem cell transplant. There was also this study depicted here, and we see that blinatumomab was associated with significant improvement in disease-free survival on the left-hand side, and overall survival on the right-hand side. Disease-free survival was 54% versus 39% at 2 years. Overall survival was 72 versus 58% at 2 years. One thing I'm going to point out here, and I'm going to come back to several times, is if you look at the blinatumomab curve, it's relatively flat. So we're not seeing late events in the curve. Now, I'm not going into the details of the full randomization, but the conclusions of that is that for patients with high risk or intermediate risk relapse, replacing 2 cycles of intensive chemotherapy with blinatumomab prior to transplant significantly improved disease-free and overall survival. It didn't show you that blinatumomab was associated with dramatically fewer grade 3 or higher adverse events in chemotherapy. Blinatumomab also improved MRD clearance, and more patients with blinatumomab were able to undergo transplant than those treated with chemotherapy. blinatumomab, improved outcome prior to transplant, but this does not address whether blinatumomab can improve outcome without transplant. Now, in parallel to this, there was a similar randomization performed in Europe, and this was published by Franco Locatelli and colleagues in the same issue of JAMA, this trial I just showed you. And it's not an identical design, it's a very similar design. Patients with high-risk first relapse of PNH ALL. In this case, they received 3 cycles of chemotherapy, and then were randomized to receive the 4th cycle of chemotherapy, or a cycle of blinatumomab prior to stem cell transplant. And here on the right-hand side, you can see that blinatumomab is associated with improved event-free survival, improved overall survival, and decreased cumulative incidence of relapse. I think this is very important. We have 2 studies with similar and identical designs performed in parallel on 2 sites in the Atlantic Ocean. Both show that blinatumomab replacement of intensive chemotherapy prior to transplant improved outcome. Now I want to turn to the other randomization in the AAL-1331 trial, the lower risk randomization. Again, all patients received 1 month of chemotherapy prior to risk stratification. The definition of low risk is shown in this slide. The standard control arm, patients received block 2 of chemotherapy, block 3 of chemotherapy, and then continuation 1, continuation 2, and maintenance therapy for about 2 years, but there was no transplant. The experimental arm, RMG, patients received block 2 of chemotherapy, but then the intensive block 3 was replaced with the cycle of blinatumomab. The remaining chemotherapy was the same, but 2 additional cycles of blinatumomab were interpolated between courses. And here we see some very interesting results. On the top slide, we look at the outcome for the approximately 2/3 of patients that had isolated or combined bone marrow relapse. And for those patients, blinatumomab significantly improved disease-free and overall survival. And the overall survival, although you probably can't see the numbers here, is 97% at 4 years, which is remarkably good for patients with relapse leukemia. In contrast, in the bottom half, patients with an isolated extramedullary relapse, of which about 80% were isolated central nervous system and 20% were isolated testicular relapse, had a very poor outcome of immunotherapy and no benefit to blinatumomab. So the conclusions we have from this study is that the patients with low-risk bone marrow or combined bone marrow relapse have excellent outcomes with RMD, blinatumomab. This uses a modified CalR3 backbone with 1 cycle of intensive chemotherapy replaced with blinatumomab and 2 additional cycles of blinatumomab. This is much less intensive than prior chemotherapy that the Children's Oncology group had used in relapse ALL. And the 97% 4-year overall survival, which would be impressive. However, this therapy with or without blinatumomab is not effective for patients with isolated central nervous system relapse. There are a relatively small number of patients with isolated testicular relapse, and those patients actually did quite well with both arms of therapy, but there are too few to make definitive statements about it. Now, I think that this is an important study that helps guide how we might use blinatumomab in the future. And so these investigators pulled data from 5 trials for relapse and refractory ALL, looking to use blinatumomab as a reintroduction regimen. All patients had to have at least 5% neuroblasts in entry, so they subdivided them into patients with 5 to 24, 25 to 49, or greater than 50% blasts. We see the patients with the lower blast count having patients with the higher blast counts, had a 3 to 4-fold higher failure rate than those with the lower blast counts. So this really suggests that blinatumomab may work best with lower disease burden and is not an ideal reintroduction strategy, although it does work for some patients. Now, there have been a number of studies recently published testing blinatumomab in newly diagnosed patients, and I'll walk through several of them. study, so Pathophysiology is an international consortium that tests studies infants less than 1 year old with ALL, which is a very high-risk subgroup. And the outcome for those patients is relatively poor. So the investigators performed a pilot study, really was designed initially to gather safety data to then perform a randomized trial. The pilot study included only 30 patients. It tested the addition of a 1 4-week cycle of blinatumomab to the standard interferon chemotherapy. However, as you can see, they compared the results to controls, matched controls from the prior trial, and you can see that the blinatumomab led to significant improvements in disease-free survival at 2 years, 82% versus 49%, and overall survival 93% versus 66%. So these results really changed how infant ALL was treated. So now blinatumomab is now included, and the investigators decided not to conduct a randomized trial of blinatumomab with these results, but rather to include blinatumomab for all patients in the current trial. Now this slide is, I think, another very important study. When blinatumomab came out and we started to see the efficacy of it and the lack of toxicity, it became a good therapy to use when patients were too sick to get standard cytotoxic chemotherapy. Unfortunately, a subset of patients with chemotherapy will develop complications, usually infections, fungal infections in the lungs, the liver, the brain, or end organ damage that precludes giving standard chemotherapy. And so many people have then tried to use blinatumomab to buy time to allow them to heal. And the UCAL group went and looked at the collective group of about 100 patients who had 1 or more cycles of blinatumomab, replacing standard chemotherapy because of toxicity. And as you can see here, the blinatumomab arm in blue was really no different than the chemotherapy arm. And I think in general, the rule of thumb is that patients who are too sick to tolerate chemotherapy do worse than those who are not too sick to tolerate chemotherapy. This really provides tantalizing data on the efficacy of blinatumomab. And recently we have had 2 randomized trials published using blinatumomab. First, we go through the adult trial, published last July in the New England Journal. And this was the adult E19 trial that tested adults 30 to 17 years old with Philadelphia chromosome negative PNH ALL. And they looked at those who were MRD negative after an induction consolidation course of chemotherapy and randomized them to receive either the standard arm, 4 cycles of chemotherapy and maintenance, or an investigational arm that had 4 cycles of blinatumomab. So overall, 488 patients entered the study. Complete remission was achieved at 80%, and 224 were MRD negative, able to be randomized, 112 to each arm. And here you see the results of that study showing significant superiority to blinatumomab. So this looks at overall survival, and we see that the hazard ratio of blinatumomab was 0.41. And again, I want to point out to you that this curve of blinatumomab is very flat after about 2 years, so we're not seeing late events. And the 3-year relapse-free survival was 80% in the chemotherapy plus blinatumomab arm versus 64% of chemotherapy. There was increased central nervous system toxicity with blinatumomab, 23% with grade 3 or higher neurologic or psychiatric side effects versus 5% with the other arm. Now, when they look at the subsets, you can see here on this plot that all subsets analyzed showed an advantage of blinatumomab. So it doesn't appear to be specific for any subtype and seems to be broadly active. And one group that is very important to me is a pediatric oncologist who's in younger patients less than 55. Here we see 4 of 66 patients with events with blinatumomab versus 20 of 65 with chemotherapy for a hazard ratio of 0.16, which is really a dramatic result. Now, in parallel to this, there have been a number of trials of blinatumomab in newly diagnosed pediatric ALL, and that have The Children's Oncology Group, AAL1731 trial, was a trial for children with newly diagnosed standard risk ALL, which is defined as an age between 1 and 10 years of age, and initial white count less than 50,000. This is a complicated slide, but basically all patients received a 3-drug induction, and at the end of it were grouped into 3 different risk categories. The standard risk favorable group was known to have a outstanding outcome greater than 98% event-free survival, greater than 99% overall survival. So those patients participated in relatively low-intensity chemotherapy arm and did not participate in randomization. The 2 other groups were standard risk average and standard risk high group. The standard risk average received less intensive post-induction therapy than the standard risk high, who were treated like high-risk patients post-induction. Both of those groups participated in randomization of either the standard chemotherapy or the standard chemotherapy with 2 cycles of blinatumomab added. And this trial is an addition trial. Additional blinatumomab cycles not replacing any elements of chemotherapy. Now, the results of this study were published recently in the New England Journal, and this trial was stopped at the time of the first interim efficacy analysis. So an efficacy analysis was planned when 40% of predicted events had occurred, and at this time there was a dramatic advantage to the blinatumomab arm that led the trial to be stopped. So 1,440 eligible patients were enrolled and randomized, half to chemotherapy plus blinatumomab and half to chemotherapy, again 2 different treatment categories. In the 3-year disease-free survival rates, which were highly statistically significant, were 96% of chemotherapy plus blinatumomab versus 88% of chemotherapy alone. This was a substantial reduction in bone marrow relapses, but no change in central nervous system relapses. Now, I'll call your attention to this hazard ratio, 0.39. Hazard ratio in the adult study was 0.41. So in both studies, in very different populations, we saw roughly a 60% decrease in failure rate with blinatumomab. This degree of reduction in event rate is really unprecedented in pediatric ortho. And here we show curves. The top are the overall cohort, disease-free survival, overall patients on the left, the middle is standard risk average, the right is standard risk high, at the bottom is the cumulative incidence of relapse. And this difference in outcome was seen in both subgroups. So for the standard risk average group, blinatumomab was 97.5% versus 90%. With chemotherapy, hazard ratio 0.33. For the standard risk high group, 94% versus 85%. Hazard ratio 0.45. It's really too early to see an overall survival difference. The 3-year cumulative incidence of relapse was 3.3% in the blinatumomab arm versus 11.8% in the chemotherapy arm. And the cumulative incidence of isolated bone marrow relapse was 1.5 versus 7.7%. So 5-fold higher rate of relapse in the chemotherapy arm as compared to blinatumomab. And again, when you look at subset analysis, the effect of blinatumomab was seen in all subsets analyzed. Adverse events, now this is a different population. These are young children who tend to have fewer side effects with blinatumomab. One side effect of interest was seizures. There were 14 seizures in the patients who received chemotherapy and 14 in the patients who received chemotherapy plus blinatumomab. So no difference in seizure rates. These patients received blinatumomab in a minimal residual disease negative state. So there were only 2 instances of cytokine release syndrome. Interestingly, there were more events of infections in the blinatumomab arm. These did not occur when the patients were receiving blinatumomab, but occurred later in therapy, suggesting some long-term impact on immune function in patients treated with blinatumomab. So the conclusion of this trial is that in addition to 2 cycles of infants in the Proton pilot study, and encouraging outcomes in the UCAL study looking at substitution of blinatumomab. Based on all these data, the standard of care for blinatumomab and for ALL has changed in the United States such that all patients, except for a small, very favorable risk subset, now receive chemotherapy plus 2 cycles of blinatumomab. In future trials, we'll begin to test if blinatumomab can allow removal of elements of therapy that will be subject to clinical trials. And I just want to leave one last thing to think of. The way we give blinatumomab is inconvenient. It's a 28-day continuous infusion. In general, patients are admitted to the hospital for 1 to 3 days to make sure they're tolerating it, and then can be discharged home if they have received the drugs for continuous infusion. For those of you in the audience who have a 2 or 3-year-old, imagine them running around with a little backpack with a 28-day continuous infusion of the drug that can't be interrupted. It's not the most convenient thing in the world. So a new formulation has been developed, which is a subcutaneous. And this is available for subcutaneous injection. So far, we've only seen very small studies published, but very encouraging results. And this is just a result from MD Anderson. I'm not going to go into it in detail because there's only 27 patients here, but they tested 2 different regimens. I'm not going to pay attention to the dose for a second, but it's weekly, ideally subcutaneous injection for the first week, and then 3 times a week for weeks 2 through 3 times a week for weeks 2 through 4. So a much more manageable schedule, and they saw extremely good results in this small pilot study. They're as good or better as those seen in similar populations with continuous infusion. And interestingly, we've seen higher levels of the drug with the subcutaneous administration. So one might consider that this could actually be more effective in addition to being more convenient. So this formulation is moving forward in clinical trials, and clinical trials are currently being designed to test this formulation in pediatrics. So with this, I will stop. I want to acknowledge my colleagues involved in these trials, particularly the study chairs of 2 trials I presented, Abigail and Laura Hogan for the relapse study, and Sumit Rachel Rao for the newly diagnosed study. Thank you very much for your time.
For the discussions of the really interesting presentations. If I may allow me, like I started first, wishing Bradley, thank you so much. It was a very efficient presentation, and we're happy to see that now it's actually training efficient program for which is will be very good for new centers who's going to start this service. I have a question regarding the flash. I know it's completion, it's experimental, maybe out of the many developments but classically, when we say large dose preparation, we always work on the late side effect. And here it's ultra high dose rate, large dose preparation. Where do you see the explanation for is it safe?
That's a great question. It looks like in all animal studies that at least a threshold of 4 breaker fractures are required to see the flash effect. It looks looks like it's better if it's 6th grade, or even better if it's 8th grade. So the other caveat to that is, like in our head and neck trial, we're going to give 1 beam per day, so that day's attack comes from that beam. So if you have a 2 or 3 beam angle plan, each day it's a different beam angle at 6th grade refraction, let's say. And it still looks like animal models, you still get a normal tissue sparing effect, even though you're reducing the dose per day. That's why I look at it as kind of like a stereotactic radiation therapy model, where you're giving 5 or fewer fractions. Not to say you're going to give more, but it looks like that would be the case if you're giving 4 or 6 grade refraction.
Do you see the current chemotherapy that says standard of care for these cancers now still looking good value, but we have a flash there?
I think it reintroduces the idea of what do we do with chemotherapy and what do we do with immunotherapy that may often work. In theory, I think it will reduce. We're seeing reduced toxicity in animals, and I know from experience that we reduce toxicity with protons compared to photons. So it stands with the reason that you would get a better, less toxicity when you use flash system therapy. Right? So we hope, but our FDA, we're walking through this step by step with it. I've been on 3 or 4 calls with the FDA. They're being very careful about what the next step is. That's why we had to start with bone metastasis and extremity, something where there was very few side effects.
Yes, please. You can introduce yourself, please.
Thank you, Dr. My name is pediatric pathologist. The question is for Dr. Hunter. Thank you for your elegant talk. So, what's your recommendation now for the high-risk patient? You did show that the benefit in different subgroup. So, outside clinical trial, would you recommend the BLINA for the group? The second question is any correlation between the CD19 expression and the response to the BLINA? And the last one is, how many cycles is the best outside clinical trial? We saw in infant 1 cycles, we saw in the relapse 2 and 3, and in adult 4. So what would be the optimal?
Thank you very much for those questions. So the first one, we really feel that based on the adult trial and the pediatric trial, that all patients with ALL should receive at least 2 cycles of blinatumomab, non-consecutive cycles. We are currently using 2 cycles, and I should clarify that we're not giving it to the ultra-low risk group at the current time. I think the number of cycles that is optimal is unknown. There are some not yet published but presented in abstract data suggestions from the adult trial of the patients who got all 4 cycles were better than patients who got better outcomes than those who got less than 4 cycles. But right now, we are using 2 cycles as a standard of care. In terms of the levels of CD19 expression, that hasn't been studied in great detail, in part because CD19 expression is in general, particularly in newly diagnosed patients, uniformly high. So you really have very few patients with PNH that have low levels of CD19 expression. I didn't discuss it, but the mechanism of resistance to CD19-directed therapies, particularly CAR T cells, has been developed of CD19 negative clones. We have seen that much less with blinatumomab, but it can be seen. In our randomized trial, there
question, Dr. Stephen Hanger. Is it a comparison between the efficacy of the CAR T cell post-4 relapse in treatment for positive leukemia in patient after inactivated in comparison with naive from inactivated, the efficacy of CAR T cell?
I'm not sure I understood your question. I think we're talking about the risk of selecting CD19 negative clones to be used.
The efficacy of CAR T cell after inactivated therapy with relapse in the current relapse acute lymphoblastic.
So our center does quite a lot of CAR T cell therapy. We initially tried to avoid treatment with blinatumomab immediately before treatment with blinatumomab immediately before CAR T cells in the relapse setting. When you look, however, at the data, patients who responded to blinatumomab, which are most of the patients, do very well with CD19-directed CAR T cells afterwards. Patients who didn't respond to blinatumomab have clearly lower rate of responding to CAR T cells. So there may be some subset of patients that are not as sensitive to immune-mediated destruction as others. Did that address your question?
Thank you. No other questions, just have two questions for Dr. Hanger. Adding two blocks of blinatumomab to treatment of childhood cancer leukemia is pretty expensive. So what are the strategies that the COG are taking to reduce the cost? So that's the first question. The second question, if we will start to reduce the backbone of the chemotherapy that we're giving right now, what's the trajectory of which blocks do you think would be feasible to remove?
First off, we don't control the cost of the drug, but it is a very expensive drug. However, you also have to look at the comparator. Pre-relapse ALL is very expensive. So if you have that 50 or 60% reduction in relapse rate, you're going to save some money there, but not treating those patients with relapse. And also the relative lack of serious infections leads to fewer hospitalizations. So, I think some detailed cost effectiveness analyses need to be done. There is reason to think that this could be an effective strategy in terms of cost. We would all love it if the cost was less, but that's not something that's in our control. I think the second part of your question is an important one, and I don't think outside of the patient who has too much toxicity to tolerate chemotherapy, at this point in time, I don't think we have the data in the diagnosed patients to take elements of therapy away outside the context of a clinical trial. Clinical trials are being developed now to do exactly that. And I think one thing you have to think about is the relative lack of CNS efficacy of blinatumomab. So you may want, if you're going to remove something, you probably don't want to remove CNS-directed therapy. For instance, you might want to remove anthracyclines, which don't really have a significant CNS-protective event. In fact, that is much more attractive than removing either methotrexate or fecal methotrexate. I think those trials need to be designed and conducted to answer that question.
Any other questions regarding the decision? Okay, then I would like to thank the speakers for the great presentation, and we conclude this session and we move on with the program.
Thank you both, Bradley. Thank you both, Hunter, for your talk. Thanks to our colleague for leading the session. The last, but not the least, for today, we will conclude with a talk from Professor Bassel, sponsored by SUMI, about new update on management of ITV. Professor Bassel is senior senior hematologist and senior colleague in the hematology field. Dr. Behoti is American and Canadian board certified in 1997. I don't think I started in medical school back then. Dr. Behoti is known for ChatGPT and is interested in artificial intelligence also.
The picture was more appropriate to the name, but that's not the picture. It could go from when they got this picture. That's an hallucination that can happen sometimes with the ChatGPT or human. Also, they can do hallucination if they don't sleep well, if they don't eat. So, it's entertaining. We will not make it. This is the last presentation and not after food day of activities, and I'd like to thank Dr. Ahmed and the organizing committee for inviting me so big. And just everyone can please for their iPhone and download two programs, ChatGPT, the white on the green, and the DeepSeek, the Chinese, both are free. If you like ChatGPT, then you can really use it. I'm using it now. So the topic of mine is about immunotherapy. It's a challenging diagnosis that we do see sometimes in different situations. Children, of course, it's different in adults during pregnancy, even during our treatment of patients with hematological malignancy. IPP can be seen. But when it used to be called ITP, tell someone crazy. Sometimes you need some people to be crazy. So we took the plasma from one patient with ITP and he injected into himself and he developed ITP. So they knew that it's not anymore idiopathic, it's immune-mediated thrombocytopenia. The ITP, we see it always, and they have different types. Could be primary, that's the most common, or secondary. And our role as physicians, we always need to rule out secondary causes according to the age group. In pediatric age, when I have, in Saudi Arabia, we do treat pediatric 14 to 18. That's our mandate. But we always, in these pediatric, we always rule out immune deficiency as a manifestation, manifesting as ITP. In adult, especially geriatric, you have to rule out malignancy. So the age HP is always important to do. But most of the cases are primary, secondary causes. You have to dig into the history, and examination. And there are basic investigations that should be done in every patient with ITP. So 80% of other patients they have ITP acquire prevalence of 9.5 per 100,000 population. Secondly, 20% of other patients they have secondary. But if you search, you might discover less manifestation of secondary, like whenever you have young women with ITP, watch later on this young woman, she might develop SLE. So no manifestation of autoimmune disease. But it will start as ITP, managed as ITP, later on you will see other manifestations. And sometimes the trigger the incidence of the secondary causes could be inherited. That's another entity that is we are facing challenges in diagnosis. whole genome or whole exome sequencing to define why you form cytopenia. Sometimes the bone marrow, the guidelines tell you don't do bone marrow. Sometimes you think there might be bone marrow failures. So in this situation, you might do bone marrow, you might do whole genome or whole exome sequencing to inherited causes. Acquired predisposing factor like chronic infection, most common H. pylori. How many they do test for H. pylori in life? If you have access or what usually by treat, you don't need to send for antibody extra tests. You will treat and you will see infections. Autoimmune disease is very important and more common in children. That's the current phase of IPE. So from diagnosis up to 3 months, it's called acute or newly diagnosed. And it will be managed because the drug we are talking about today is only for chronic IPE. So unfortunately, you have to wait for 12 months to be able to use TP or receptor antibodies. So for newly diagnosed up to 3 months, it's called newly diagnosed. From 3 to 12, persistent thrombocytopenia, it's the time you go take other workup, but you have to treat. If it is either relapsing or persistent after 12 months, it's the chronic IPE. And that's the area currently they approve TPO in this treatment. Pediatric sometimes spontaneous remission care, that's always they don't treat it, they observe, they say you but relapse care after remission, and you will see these cases. So childhood onset typically precipitated by illness, and that's why it could be respiratory viral infection. Doesn't progress to be chronic or persistent, and resolve with treatment or sometimes without treatment. Of course, children always they have better outcome, whether leukemia, IPE, or very jealous. Severe non-immune bleeding occurs in children. These types, if you see a child with IPE with intracranial hemorrhage, for example, it's not. It's other types of immune thrombocytopenia. There is the HPA1, there might be other entities other than the IPE. So when there's serious bleeding, it's other types of IPE. In adults, as I mentioned, mostly it's primary, you have to follow and investigate. The incidence increase with age. Relapse after treatment with steroid. Unfortunately, till now, steroid is the first line as per guidelines. You cannot exceed go to TPO. I wish till we have studies of upfront use of TPO receptor agonist in the first line, but we can currently steroid is the mainstay of the first line treatment with IPE and acute setting. If the patient is progressing from newly diagnosed to persistent, then chronic, then it's the place for TPO receptor agonist. The incidence of serious bleeding can occur in adults, but this is common. Diagnosis, you know, it's history, examination, and that's the ICR 2019 guidelines. If you really go through the table, it's important to exclude secondary causes. And as I mentioned, Omar not indicated, however, I came across many cases, like Claude platelet, they gave steroid, they didn't review the blood film, the patient ended having Burkitt. film is a single case that we can use ChatGPT AI to interpret, but you have to request the blood film. If you don't request the blood film, you will miss many things. You might miss leukemia, you might miss TNA. So lately we had a patient who presented with low platelet, we thought it's ITP, but no. When the blood film was good, there was schistocytes. So it's immediately moved from usual ITP care to life-threatening situation, and patient was admitted and managed successfully. So that's why you have to be systematic. But the most important test, in my opinion, is the blood film. If the blood film is showing any abnormality, dysplastic, neoplastic, then well, has to be done. If you have a family history, that's an entity where you can really do the whole genome or whole exome sequencing. H. pylori, as I said, I don't test that. And of course, the diagnostics are really always, but the most important point is to rule out immune deficiency. Please. Lately, we had a patient who had ITP. Then not only hemolytic anemia, he was treated as pediatric, and then he came with thrombosis, so we had antiphospholipid. And then what was last, and he was diagnosed as common variable immunodeficiency. And it is a fact that these patients, they are at risk of development of lymphoma. So what he ended up with, he presented, now he is admitted or made discharge. He presented with vertebrae. You can imagine moving from autoimmune disease, this over a decade, I would say. Over 10 years, I have been following, but when the case is more difficult, I give it to my colleague, Dr. William. It's more difficult cases. If it is simple, it's me. If it is serious diagnosis, my team, we have to knife. So the point, there is one diagnosis there, but you have to monitor. The diagnosis can change, please. The phases we talked about the so ITP management, we have the breakthrough in management. Unfortunately, people talk about rituximab before they talk about TPO receptor agonists. Where the evidence for rituximab use in ITP is off-label. It is not for the rituximab, its development was for follicular lymphoma and chronic lymphocytic leukemia, and then in 2000 for diffuse large B-cell lymphoma, so malignancy. And then it's used in autoimmune disease, the ITP, IPD, all these diseases is off-label. But the real drugs that were tested in phase 1, phase 2, phase 3, phase 4 marketing is the TPO, thrombopoietin receptor agonist. Based on these different phases, we have currently 2 drugs available in Saudi Arabia. The first one introduced was Elton. The first one used actually was the POSS, which is subcutaneous injection. Then came Elton. This was 2006, 7, 8. I was in King Fan University. And then the other is a newly born in the second decade of the 21st century. And there is only a new one coming from China, is called Lusotinoma. So, but not yet available. And there are other drugs that are this is simple table, but there is you are right. When you want to compare the ADA versus Elton versus Rom. So both the ADA and Elton, they are non-peptide, small molecule, they work on the transmembrane, whereas the romoplostin is Fc peptide fusion, it works on the extracellular domain. So there is some difference. What we can see is the drug interaction. So the L2 So that's why the lab has the advantage of being without food, with or without, it's not affected by the food. The other point I want to make is the liver toxicity. It has its liver toxicity actually causing in certain populations like Far East, Chinese, Asian, you have to use weight because based on the studies they notice that they have higher toxicities, whereas the other it's safe. The indication of these drugs are approved only for chronic ITP, not upfront, not for persistent. So you have to wait for 12 months. But sometimes that's the guidelines. You can go off-label medication. But the point here that ABA doesn't need food and it's safe with doesn't cause liver toxicity. Sometimes they say it causes the ABA. Now I have one patient on ABA tumor. So it's been challenged. This patient has been on different types. He has, I will call it secondary, because he has patient disease, followed by oncology, clinical ITP, and he was treated since 2011. Eltonobal not responding. He was on ronroxol and IVIG. If he doesn't take these two drugs, his platelet will drop. I got ABA, and I'm using ChatGPT to adjust the dose. So I started with 20, then 14. So I saw him yesterday in the clinic, and his platelet were 173, so we used those. And reviewed the blood film. Also, it's another important message. Be careful to take the number alone. So you have to review the blood film, make sure that there is no clumping that's causing pseudothrombocytopenia. So I reviewed the blood film multiple times, sometimes 1 week. So within, I would say, 5 to 8 days he responded, and then you will reduce the dose according to the platelet count. So instead of giving daily, you can give it once a week or twice a week, and you monitor the platelet count. And when the platelet count above 250, you stop, and you will monitor the patient with the weekly or every 2 weeks platelet count. So the ABA has an advantage, rapid response, dose reduction, don't need to get it daily. Maximum dose is 4, never exceed this dose. Minimum dose you can go up to 20 once a week, not daily. So with the use of this drug, but you have to monitor. And with every request of CDC, please make blood film. If you don't do blood film, you might be misled by platelet count giving you knowledge or pseudothrombocytopenia. So that's the way I learned from ChatGPT how to monitor this. First, for me, this was the first patient I'm using the in him. If you look at the meta-analysis, the TPO significantly increased platelet response compared to the standard of care. Multiple studies show this. If you look at the risk-reduced rates of bleeding, of course, show the ABA because it's more effective in increasing the platelet count. And that's the proposed treatment algorithm for ITP. Steroid, still different doses, DEXA, prednisone. And if the patient has chronic ITP, they will go to TPO receptor agonist. Rituximab or other drugs still not the clear second line for chronic ITP after failing steroid is the TPO receptor agonist. That's the structure of the ABA. Just to know that the ABA has the advantage, it is synergistic with the endogenous hormone produced. So that's another advantage with the ABA. How to switch? So So the patient he was on only, it's once a week, so I have to wait 1 week and then to start the if the patient is on L-tone, you have to wait for 24 hours and then you will start that point of food interaction, and it was already demonstrated, and the approved indication went through different stages of clinical trials, and that's the 20 to 40 months daily initially, but then you monitor, you lower, use ChatGPT to adjust the dose, and then you might end up with 20 once a week, or you can discontinue. If the patient rated above 250, you can discontinue and monitor every 2 weeks, every 4 weeks, and then if platelet drop, you can. The real challenge I have, because I have monitors in pregnancy, is what to do with pregnancy. Of course, these drugs not approved during pregnancy will be off reports, will be used, but most of the time I monitor and use those prednisone IVIG. That's another story. But pregnancy is a real challenge when you want to manage patients with ITP during pregnancy, and we have few patients with these. As I mentioned, no drug interaction with the ABA. If the patient misses dose, he doesn't need to worry. Just if he misses the dose, take it as the time number, but don't take 2 doses to compensate. Time out. So I will stop here, and then I will be happy to do this. Please download ChatGPT. I believe it's about what stocks in ChatGPT company. But these Chinese companies, they make me unhappy. DeepSeek. It's free, but it is deceiving. Like the Chinese cars. You know, this Chinese car. Oh, I should say that 24-hour Chinese car. That's why it's cheap to use it. So check it.
Thank you, Dr. Bassam. Thank you, everyone. By this, we will conclude our day for today. We'll see you all tomorrow, inshallah, at 8. Inshallah, we'll start 7:40.